that side. And it's a quick test. You would test, you're testing multiple muscles, but it brings out weakness. And you would know immediately if there's a weakness or not. In some situations, you do want to know quickly if there's a weakness or not. Another way to do it is this. You ask the patient to wait for 15-30 seconds. And once again, what would happen is that the fingers would sort of lose their sharpness, and you would sort of, the wrist will cop, and then you'll sort of have that happen. And so these are tests that bring out subtle, so these are tests that would bring out subtle weakness. So do not forget to do a drift if you're asked to do one maneuver to pick out weakness. And this is a similar maneuver for the lower extremities, but we're not going to demonstrate it for the purposes of this video. So that brings us to the end of the demonstration in muscle power. Do not forget to understand the grading of muscle power. So 0 is no movement at all. 1 means you look at the muscle and you see a little bit of movement, but it doesn't lead to joint movement. You see sort of the person trying. So for example, Yusuf would, I would ask Yusuf, he would be able to do it. But if the power were 1, you would sort of look and see the muscle moving, but you would not see a movement at the joint. If the power is 2, Yusuf would sort of be able to do it only if I put it with gravity. If I put his arm like that and sort of rested it on the table, he would sort of be able to flex his elbow. But when I put it like this and say, well, do it against gravity, he wouldn't be able to do it. People with a power of 3 would be able to do this. People with a power of 4 would be able to resist, partly, but then I would break it. People with a power of 5 will be able to resist full movement, like that. So the power grading is important. And this brings us to the end of the muscle power examination. Next is tone. And what you do is you count. Tone is passive, resistance to passive movement. So you ask the patient to relax, and you take one joint at a time. You control the joint, and you sort of move first slowly. We can start here at the wrist in a sort of circular movement, and then you can move quickly like that. And there's a reason for that, because there are 2 types of increase in tone. Hypertonia, there's spasticity and rigidity. Rigidity is present throughout the movement, throughout the passive movement, meaning you'd ask the patient to relax, but still they find a lot of resistance. You find it hard to move the joint. Whereas in spasticity, you might not find a problem moving the joint when you move it slowly, but when you move it quickly, you would feel abnormal resistance. So you would see something like this, for example. You would catch and then start moving again. So you start at the wrist, once again, circular movement, and then quick movements, looking for spasticity. Then you move to the radio-ulnar joint. Notice that I'm holding the joint from above and below. So I'm testing only one joint at a time. The wrist is stable. I've stabilized the wrist with my hand and finger. And you do this. So you start slow and you move quickly. If you're looking for spasticity, you want to move quickly. So there's no spasticity here. If there were spasticity, you would see something perhaps like this. You sort of get a catch. It's called a spastic catch. An increase in tone seen when you move the joint rather quickly that you would not see if you move the joint slowly. And a pitfall I want to mention here is that one should go through the full range of motion, not just like that one. We're going to go through the full range of motion. And obviously you want to do right, and then left, and then here, and then here. And then you want to do like this. This is at the elbow now. So first slowly and then quickly. And then here, slowly and quickly. So if there's a spastic catch, you'll sort of see something like this, which is a sign of spasticity, which is a sign of upper motor neuron pyramidal lesion. Whereas rigidity is a sign of extrapyramidal lesion, seen often in Parkinson's disease. And you do the same thing. Yusuf, no Allah harak. And you do the same thing with the lower extremity. No Allah harak. And you sort of ask the patient to relax. And you, so it's important to sort of wiggling his legs to see that his feet are sort of moving a little bit, which tells me that he is relaxed, because if he was not relaxed, his feet would move with me. Then I would hold his leg from under his knee and I would sort of lift it slowly. And in a normal, relaxed person, the foot would sort of rub against the bed like this. And then I would grip it up quickly and it would still stay on the bed. If there was spasticity, we would get a catch. And if you got a catch like this, it would be a power here that's enough to raise his leg, raise his foot off the bed. So that's a sign of spasticity at the knees. And you do the same thing at the feet. What you want to do is, after you do your passive movement, is you check for something called clonus. You do that. And if there is clonus, what will happen is that the foot will start jerking like that. And if it happens continuously, it's called sustained clonus, and that's a sign of upper motor neuron deficits. So that's muscle tone. So the pitfalls are: have the patient relaxed, control the joint from above and below, move to the full range of motion, and move slow and fast. Look for spasticity and rigidity. Do not forget clonus in the feet. So moving on to reflexes. So we'll start with deep tendon reflexes. You need a reflex hammer, and you start each joint at a time. So this is the biceps tendon. I can feel it. You sort of expose the muscle you are going to test, and that's the biceps tendon. I can feel it. So you check for the tendon, you put your finger on the tendon, and you simply hit the tendon with the hammer. And you can perhaps see the movement. If you notice that his forearm is moving slightly, and you can see that I can certainly feel it. I'm hoping that you can see it on the video. And what you do is you compare right and left. Once again, you expose the muscle. You ask the patient to relax. And obviously, see, once again, I'm controlling the joint. I have my finger on the tendon, and I hit my finger. I hope that this is clear. So notice that I'm not shy. It is really unheard of to have someone hurt a patient seriously because of deep tendon reflexes. So you want to see a reflex arc, sort of like that. You don't want to do this or this. That's just not sufficient. And you don't want to do that. The movement is not at the shoulder, movement is at the wrist. You just flick it like that. So that's biceps, C5 and 6. Here is triceps. Triceps is a big muscle. You expose it, and the tendon is right here above the elbow, and you just go like that. You make sure the patient's relaxed. I'm sort of controlling the joint, and you go like that. And I'm looking at the muscle, and you can see it. Once again, we expose the muscle. Make sure he's relaxed. That's one way to do it. And you just hit. You can see that his forearm is extending. One other way to do it is to do this. And just carry the arm. And just go like that. So this way it's easier to demonstrate, but you don't really have to do it if you're sort of looking at it and you feel it and you see it. And you compare right and left. It's important to compare right and left. So biceps, triceps, people should do the brachioradialis. The brachioradialis is just where you would wear your watch. So it goes like that. It's fine to do it directly on the tendon. It's like that. And the reflex is a little pronation, so look at it carefully. A little pronation and a little flexion. It's there, and it's the same on both sides. And then we move on to the lower extremities. We want to demonstrate the knee jerk. So I have my hand on the quadriceps and I'm feeling for the tendon. This is the patella, this is the tibial tuberosity, two bony landmarks, and the tendon is between them. It's not bony. And I sort of just go like that. And what you expect to see is what we just saw. Once again, here's the patella, here is the tibial tuberosity tendon, and you hit. You compare right and left. Two are equal. So that's what you do with the knee. And then you do the ankle. There are multiple ways one can do the ankle. The most important point is that one should dorsiflex the ankle slightly, not all the way like that, and certainly not leave it just like that, where the tendon would not be stretched. You want to stretch the tendon a little bit, and you just go like that. The Achilles tendon, and the reflex is a little bit of a downward movement and sort of dorsiflexion. Let's demonstrate again. Let's do it on the other side. So once again, I flex it a little bit, dorsiflex it a little bit, and use the reflex, plantar flexion. You can see that his foot is moving downwards. And once again, don't be shy. It is unheard of that anyone got any significant injury from the deep tendon reflex performance. So once again, biceps, triceps, brachioradialis, knees, ankles. The next point I want to demonstrate is the plantar responses. So next thing is plantar responses. What you want to do, I hope this is going to come out in the camera, is you want to apply a sort of noxious stimulus, like the tip of your hammer if it's a little sharp, nothing too sharp obviously, and you want to go on the lateral part of the foot, not the medial part, the lateral part of the foot. This is the lateral side, and you sort of want to put your noxious stimulus right there, and then you want to move up and sort of immediately. And you want to look at your big toe. The big toe is, the normal response is for it to go down, and the abnormal response is for it to go up. And what I find very helpful is to put your finger sort of under the first metatarsal here and push the foot a little backwards, so to put the toe in its neutral position. And there you go, just like that. And you look for the very first movements. You can clearly see that his toe went down. It's called a down going toe, or the negative Babinski sign. And you do it on the other side. And once again, down going toe. I can demonstrate it one more time. Down going toe. In cases of upper motor neuron deficits, the toe will go up when you do that. It's called the up going toe. And that is a very helpful sign in terms of its indication that there is an upper motor neuron lesion. And with that, I think we can conclude the motor exam. So we went through inspection, tone, power, and reflexes. So we can stop here. So the last component of the neurological exam has classically been the cerebellar examination, test of coordination and gait. And the cerebellum can be thought of as the timer of the nervous system, especially a timer of movement. It has other functions too that are beyond the scope of this video. And cerebellar disorders can present themselves with many signs, and it starts with just with observation. One can see tremors of the body, just like that, or head tremors, just like that, which I do not see here. Spontaneous movement might also be tremulous of the hands, for example. One can look at the eyes and see nystagmus. The cerebellar lesions cause nystagmus in the eyes, horizontal or vertical. And one can start to see or can hear speech problem. So one will want to listen to people talk and see if the tone of their speech is different. The cerebellar lesions cause something called staccato speech or scanning speech, where speech would be low and then it would go higher and then it would be lower and then it would go higher and then it would go lower, just like that, as if someone is scanning in one of those old radios. So cerebellar lesion affects speech. And then we want to demonstrate the other signs in the periphery of cerebellar lesions. One of them is the finger nose test, which we mentioned before when we were talking about inspecting for abnormal movements. So we will demonstrate it again. Yusuf, أنس إصبعي، أنس أنفك، أنس إصبعي، أنس أنفك، أنس إصبعي. Notice that I'm moving the stimulus, and I'm having him stretch his hand. One pitfall is to go close like that, and that's not the right way to do it. The right way to do it is to have him stretch make it a little hard, make it hard enough. وليد الثانية نفس الشيء. البداية الثانية. جميل. وبعدين حط إصبعك قدام إصبعك كده كأنه قدام، لا تلمسني وتعال معي قدامي بالضبط. So people with cerebellar disorders will tend to past point. So for example, if there was a cerebellar lesion, I would move my hand like this, and the Yusuf's finger would sort of pass point and come back, and pass point and come back, and sort of take its time to sort of pass point me and then come back before settling in front of me. And the same thing would happen with finger nose testing. The other thing people can see is something called dysdiadochokinesia, which is difficulty in maintaining a rhythm of a specific movement, or difficulties with repetitive movements. So يوسف حط يدك كده، سوي زي كده. نفس الشيء باليد الثانية. So people with cerebellar lesions would possibly do something like that. They would not be able to maintain the rhythm. One other way to do it, يوسف حط يدك كده على السرير الله يسعدك وبس سوي كده. So people with cerebellar disorders might potentially do this. With unequal strength and distance between the taps. The other thing you can do is you can have people do this. So people with cerebellar disorders will not be able to sort of do it rhythmically and might do. So you're looking for a loss of rhythm for the movement. So كده tip increase. هنا في البداية بقى على الخط زي كده. أيوه. Again, it requires accuracy and timing, and people with cerebellar disorders might have difficulty doing that. The next thing we want to demonstrate is what's called the check sign, or the rebound phenomenon. So كده يوسف. Before you do it, you want to put your hand like that, and then should نفسك. Should I? And you would leave suddenly. You put your hand like this to prevent the person from hitting themselves. So Yusuf was able to maintain or stop himself from hitting himself. Someone with a cerebellar disorder will not be able to time it because the cerebellum is a timer. He won't be able to stop himself. So أسحب نفسك عليه. So as you can see, Yusuf was able to stop himself. Someone with a cerebellar lesion might sort of hit your hand instead, or hit his face. So it's called the rebound sign, and you want to do it on the other side too. The rebound sign, or the check sign. One other thing to do, يوسف نام على ظهرك ولا خليك. بعدين جيب كعبك، المس في ركبتك، وانزل على الجولة زي كده. ايوه فوق تاني. معلش سويها كم مرة. نفس الرجل يوسف عدة مرات. ايوه فوق تاني. وتحت. ايوه كمل كمان. That's good. And you do it on the other side as well. So people with cerebellar disorders will have their heel unable to go down the shin just like that, and will sort of sway right and left over the shin. يوسف اجلس معي شوف. رجلك تلمس الأرض سوي زي كده. Sort of similar to what we did earlier with the finger tapping, but with the foot here. The other time. So that was called the heel nation. This is called foot tapping. These are all signs of cerebellar disorder. And then you want to have people walk. First, which is the gait examination. You have people say, امشي كده عادي. من هنا وارجع تاني. مش عادي. دور. وارجع. امشي تاني. اوكي. بعدين دور. وتقدر تمشي زي كده. It's called tandem gait, heel toe walking. Stop. It's good. Turn around. دير وجهك كده. وخلاص رجولك كده قريب من بعض مرة. See, people with cerebellar disorder will have difficulty maintaining their stance when you narrow the base. So people with cerebellar disorder will tend to walk with a wide-based gait like that, and will tend to veer to one side or the other. If a right cerebellar lesion will veer towards the right, left cerebellar lesion will veer towards the left. But as you can see, Yusuf is able to maintain his stance with a very narrow base without problems. Even if you tip him over a little bit, he will still be able to maintain his base. So once again, you wanna test gait, normal walking, and then tandem gait or heel toe walking, which Yusuf did to us, and then you want to have them stand on a narrow base and try to tip them over a little bit. Do not forget that people with a unilateral cerebellar problem will have ipsilateral cerebellar signs. I mean, if you have a right cerebellar lesion, you will have dysmetria of your fingernail cyst on the right. You will have problem with your heel nation on the right. You will veer towards the right. You will sway towards the right when you're walking. And this concludes our cerebellar examination. The next part of the examination is the sensory examination. And one can spend hours to do the sensory examination if a clear hypothesis that one is looking for is formulated beforehand. So how you do it and how long you take to do it depends on what you're looking for. In general, there are three modalities that one wants to test: touch and pressure, pain and temperature, and then vibration and proprioception. So meaning there are two major pathways: the anterolateral system taking pain and temperature, a little bit of touch, and the posterior column pathway, which takes vibration and proprioception. And we will demonstrate here how it's done. So touch is pretty easy. All you want to do is you want to have a piece of cotton or a piece of tissue, and you can ask the patient if they're feeling what you're stimulating them with or not. So you say passes, and you can compare with the other side. Passes, or you can go along the forearm, and you ask people if it changes. My favorite, And you can do the same with lower extremities. So you ask people if they're feeling. How's it change? هنا زي بعض. And then you compare distally with proximally. وهنا وهنا ما في فرق. ما في فرق. ولا هنا. So you can go all the way up to compare distally with proximally, which we will not completely demonstrate here. So you're already aware of how to test for touch, and you are aware of one should compare side to side to look for hemispheric or spinal cord lesions, and distally with proximally in order to look for signs of peripheral neuropathy or spinal cord problems. The next thing we'll demonstrate is pinprick. One can use a pin that's dulled a little bit. It needs not be too sharp. You do not use needles that are used for blood draw, and do not push too strongly, because you don't want to leave a blood mark where you're testing. And people often start with the lower extremity like that. Yusuf passes? ايش حاسس فيه؟ is it sharp؟ حادة؟ زي
أيوة.
كأنها إبرة؟ وهنا كمان نفس الشيء؟
ايوه حاد.
اوكي. في فرق بين هذه وهذه؟
ايوه في فرق.
في فرق، اوكي. ايش الفرق؟ ثاني واحدة ايش بها؟
ما هي حادة
ما
زي.
هي حادة، اوكي. and then you go up. في فرق؟ كلها حادة؟
هذه حادة كلها.
ولا هنا؟
حادة.
ما في فرق بين الجهتين.
لا ما في.
And then you sort of can go all the way up and you can compare the L4 for example. هنا في فرق من هنا.
لا ما في.
So the L4 with the L5. So it depends on what you're doing. If you can compare your dermatomes, if you're thinking of a nerve root lesion, or you can compare different nerves, for example. حاسس هنا,
ايوه.
which is median territory. وهنا
ايوه.
زي بعض. So that's ulnar territory. You can even compare one finger. So one is median and one is ulnar. هنا
ايوه.
وهنا زي بعض.
ايوه.
People with carpal tunnel syndrome, for example, will be unable, will tell you that there is a difference between the medial and lateral halves of the fourth finger. One important thing you want to do if you're suspecting a spinal cord lesion is you want to test it at the back. So يوسف حاسس هنا
ايوه.
وما في فرق وانا بطلع.
لا ما في.
So people with a spinal cord lesion at T4, for example, will tell you they're not hearing it, that they're not feeling it, or that